It is really my great pleasure to introduce our speaker this morning. This is Dr. Aliyah Sohani. She's visiting us from Boston, Massachusetts, where she's an assistant professor at Harvard Medical School, and she's a pathologist at Massachusetts General Hospital. She's a medical director of the Hematology Laboratory at Mass General, and wears different hats. She signs out hematopathology, coagulation, and hemoglobin electrophoresis. Dr. Sohani received her Doctor of Medicine from Harvard Medical School, and then completed her anatomic and clinical pathology residency, fellowship in surgical pathology, and fellowship in hematopathology, all at Massachusetts General Hospital. So she's been there for a while now. She has well over 50 peer-reviewed publications, numerous abstracts, and is a national and international speaker. I also know firsthand that she is a very kind and generous person and is a very great mentor and friend. So welcome, Aliyah, and we look forward to your presentation.
Thanks so much, Elizabeth. That was such a nice introduction, and it's really a great honor to come and present to you today on actually a topic that for me is really close to my heart, and it's not sort of the main thing that I do. Sometimes I wish I had kind of more time for it, and that's really some of the global health efforts that I spent some time in partnership with a lot of, and with support from a lot of other people in our department and across the country. And there's so many ways to approach this topic, and that was actually one of the things that I struggled with in putting together this presentation, is whether to focus on kind of infrastructure building or training. And I think there's so many ways to approach global health and pathology, and it just highlights so many ways that we can be involved as pathologists, even though we sometimes perhaps don't think of ourselves as being kind of at the forefront of global medicine. But I think something to always keep in mind, especially with cancer care and the importance of cancer care, is how critical a diagnosis is. And so that's really going to be the focus of my talk, is how we as pathologists, particularly many of us based at academic medical centers, can be supportive of improving diagnosis of pathology conditions, and also supporting discovery, so supporting research-oriented collaborations. So I have no relevant conflicts of interest to disclose. And so just to start off with kind of a general overview, obviously pathology in the developing world faces many challenges of limited resources, and in particular there's a shortage of trained specialists and trained laboratory personnel. So in terms of pathology training programs. And one other issue that has come to the forefront, and it's probably an issue that's been true here historically, is just the perception of pathology as a specialty by other medical specialists. It's kind of not, it's sort of given short shrift. A lot of people historically here have sometimes seen pathology as a very kind of forensics-focused specialty, that all we do is, you know, do autopsies and look after the dead, and everything that we do is sort of after the fact. And we all know here that that's not true, but unfortunately it's a perception that's been slower to change in the developing world. And as a result, many medical trainees coming out of medical schools there do not really see it as a very necessarily exciting specialty to go into. And so changing that phenomenon is also a challenge. So one other thing that we've encountered, and that others have encountered, is there's kind of this intellectual brain drain of medical professionals from developing to developed countries. This is true across specialties, but I think particularly in pathology, sometimes what happens is we make a good faith effort to support a pathologist in a developing country to come and do, you know, a rotation or spend some time in our department, and then they like it so much they end up staying. They end up figuring out a way they may repeat their residency, repeat their training, but they figure out a way to stick around because they realize what great opportunities there are in this field here. And so that's another thing, is that it's not just so much the quality of equipment and facilities, but just the lack of opportunities for just things that we sort of take for granted, like continued medical education courses, advanced fellowship training, and even just the opportunity to do research and advance one's career. And then all of this is in the setting of a really challenging backdrop with a growing burden of non-communicable diseases. So in the developing world, the focus over the last several decades has been on kind of the three big communicable diseases, HIV, TB, and malaria, but that is shifting now since cancer, diabetes, heart disease, these are all becoming more prevalent as the population ages and as infectious diseases have become more controllable. And in fact, WHO statistics project that 70% of newly reported cancers by the year 2030, so only 14 years from now, will occur in the developing world. So the burden of cancer worldwide will actually be in resource-challenged settings. So how are we, as pathologists, practicing in a very resource-rich environment? How can we help? Just to kind of highlight this, the shortage issue, I'm just taking one particular case example in pathology in Tanzania, and I was actually mentioning to Amy just before we started, this is the country where I was born. I was born in Dar es Salaam, which is the capital, shown here. A very, actually very picturesque setting right on the coast of the Indian Ocean. So this is a country with a population, this data is probably a couple of years old, of about 48 million people, and there are around 900 physicians, so 1 per 50,000 people, but only 22 pathologists. And so just to put that in perspective, that's 1 pathologist per 2 million people. So in sub-Saharan Africa as a whole, there are certainly somewhat more developed countries like Kenya and South Africa, but even when you consider the pathologists in those countries and you look at all of sub-Saharan Africa as a whole, you're looking at about 1 pathologist per 500,000 people. And here, just by comparison, I mean, in the United States, I think the average is 1 per 15 to 20,000 people. So that's just pathologists, obviously not physicians, but just to think about the growing burden of cancer, the amount of cancer being diagnosed as one of many, of course, diagnoses that require pathologist input. In terms of laboratory technologists, that's also another challenge. There's in this country, about 1 per 25,000 people, lab techs. And there are actually 2 lab tech training schools, and there are pathology training programs, so sort of residency programs. They're actually called Master of Medicine programs, so it's sort of a master's degree equivalent in Kenya and South Africa. But essentially, there are not really any subspecialty fellowship training programs. In Tanzania presently, there's no immunohistochemistry lab countrywide, but there are immunohistochemistry labs in neighboring countries, so that is an option. Obviously, this poses immense diagnostic challenges, particularly in areas where immunostains are essentially necessary for most diagnoses, and particularly where they're important for prognostic information. So how do you treat breast cancer if you don't have access to ER staining and you don't know whether the tumor is going to be Herceptin sensitive? So I think those are really key issues that, making a diagnosis and knowing how to treat, it obviously is going to impact treatment. And as far as molecular diagnostics and cytogenetics, essentially, at least in this country, it's non-existent. So one way that we've approached this is to develop a telepathology system that's been based at MGH. Obviously, telepathology has some potential advantages in terms of providing diagnostic support, second opinion consultations, and we've also tried to use it as a model for ongoing training and also providing highlighting some opportunities for collaborative research. And so I'm going to talk about that during the first half of my presentation. Obviously, there are some challenges involved related to the cost of the equipment, maintenance of the equipment, and servicing and repair, training of users, and one issue as well, of course, is internet connectivity and high volume of data transmission. But a lot of these issues, I would kind of argue, can be overcome depending on the platform that you choose. And certainly here, where we might have the focus on something like a whole slide imaging-based platform, maybe something a little simpler, maybe more practical in a resource-challenged setting. And so that's the approach that we've taken. One thing that we've been able to do is also partner with a best practice model in healthcare education and delivery to really define kind of a successful model, we hope, one that's relevant, scalable, replicable, as well as sustainable. And so I just want to talk briefly about the Aga Khan Development Network, which is an NGO that I've been volunteering with since high school, and that's sort of something that I was able to bring in when I was in a position to be able to offer something back. So this is a group of development agencies working to improve living conditions and opportunities in the developing world. And while the agencies are mainly focused in Asia and Eastern and Southern Africa, they really conduct their programs without regard to faith, gender, or ethnic or country of origin. So one of the development agencies is the Aga Khan Health Services. So besides healthcare, they do have mandates in other areas as well, like education, rural support, infrastructure building, architecture, arts and culture, microfinance. So this is one of several areas. But the health services is actually a comprehensive private, not-for-profit health care system. That's one of the most widely sort of prevalent private healthcare systems in the developing world. Again, NGO funded. They have community and private healthcare programs. You can see a large number of healthcare facilities as well as 9 hospitals. And there's also a School of Medicine and Nursing based at the Aga Khan University in Pakistan, in Karachi, its capital. But there's also a regional network of 4 hospitals in Eastern Africa. There's an Aga Khan University Hospital, so an academic medical center in Nairobi, which is the capital of Kenya. And then there's Aga Khan hospitals in Kisumu and Mombasa, Kenya, and in Dar es Salaam, which is actually the hospital where I was born. So this is a map just kind of showing these areas. So here's Nairobi in Kenya, and Kisumu is right on the equator. It's located on Lake Victoria, really beautiful, kind of picturesque setting. And Mombasa is equally, again, beautiful, just really like a beach town on the coast of the Indian Ocean. And then here's Dar. So I've really been fortunate to have the opportunity to actually go back and visit all of these places. And what we did was we established in early 2008 now, so can't believe it's been that long, 8 years, an initiative with the AKDN network in Eastern Africa, and it actually started with that one hospital in Tanzania in Dar es Salaam. And what we did, and it was expanded the following year to include all 4 hospitals in the network, and what we did was we equipped each site with a multi-headed microscope, digital camera, and software to take still images, still photographs of cases. This was something that they really didn't have at the time. So all of the equipment was either donated from MGH from used microscopes. There was one year where the department chair said, we need new microscopes, all our side-out microscopes are old. But not really that old, they were very functional, and so they were kind enough to donate a couple for this purpose. Some of the pathologists who wanted new microscopes donated their double-headed microscopes. And then we also were able to get cameras, and some of the equipment needed to be purchased, and there's a funding arm of the Aga Khan Development Network that helped to raise funds for this purpose. So that was all very exciting. And then we performed some site visits to set these up and train them in how to just take care of these and how to maintain the camera, how to troubleshoot if there were issues. There was actually a telepathology server. It was really more of a telemedicine server that could be adapted for pathology, hosted by the eHealth Center that was part of the AKU. That allowed for still image-based consultations. And essentially, as they posted cases, I helped to triage them, and then I would essentially triage them for review by my subspecialist colleagues within the department. One thing I just want to mention before I go on is just the importance of just the multi-headed microscope. So we actually, besides the double-headed microscope, which was for the smaller hospitals, the larger hospitals, and particularly the University Hospital in Nairobi, we provided them with, I think it was like a 5 or 6-headed, multi-headed microscope. And up until that point, they didn't actually have multi-headed microscopes in the department. So even though they had a training program, they really had no way of reviewing cases as a group. They didn't really have a consensus conference because it's very difficult to really have a consensus when you have to look at cases individually. And I think what the multi-headed microscope, more than even perhaps the telepathology, is it's allowed for much more collaboration within the department as well as outside the department. So it's really allowed clinicians in the hospital to come and review cases with the pathologist. So it's really brought the clinicians into the lab, which was something that we sort of, again, take for granted. We have clinicians come by, we actually get annoyed, like, why are you bothering me about this case? But, for them to have the clinicians come to the lab, suddenly really be interested in seeing their cases was a really important aspect, and maybe actually an unexpected but pleasant outcome out of all of this. So this is just a screenshot of what the system we were using at the time looked like. So it allowed you to post, or the pathologist post, who was hosting the case, to include a history, and they would upload several images. Several actually could be uploaded at one time, but they're all still images. And if you clicked on one of these thumbnails, they would expand, and so this is a stromal lesion of the breast. And then once you've reviewed the images, and of course this could be done asynchronously, so a pathologist in Tanzania, so that's like 8 hours ahead of US time, Eastern time, could then post, and then the following morning, you might look at the case, something they posted the night before, which was morning for them. So then you could post a response. And I think the thing that we felt was really important was that instead of just kind of giving a diagnosis and saying this looks like a fibroadenoma, we actually gave a little bit more than that. So it was sort of like, this is a differential diagnosis, these are the other things to consider, as well as to post additional information like either journal articles. In this case, I decided to emphasize, in consultation with the breast pathologist in our department, how important gross evaluation was to distinguishing between a fibroadenoma and a phylloides tumor, which was the concern in this case because it was such a large breast mass. And so just to summarize the teleconsultation activity we've had to date, and again, just to emphasize, this is all still image-based telepathology. We've had nearly 200 cases posted. You can see each case has about 13 images. Our turnaround time is not super fast, but 5 days is actually a pretty reasonable amount of time as far as our referral pathologists are concerned, referring pathologists. And interestingly, still images have included not just microscopic images, but gross and clinical images, particularly for skin lesions, as I'll show you, radiology, and more recently, even flow cytometry, scatter plots, and FISH images for some of the labs that have been able to adapt that technology into their settings. And in about 93% of cases, we've been able to provide a complete or at least a partial diagnosis. Partial meaning it's probably enough to get them enough information to give a reasonable starting point for treatment or follow-up. And the case responses have really been with this educational emphasis. We want to discuss the differential, diagnostic pearls and pitfalls, because the purpose isn't so much in our minds to just give a diagnosis, but to enable them to know how to handle the same type of case should they encounter it in the future. So it's really about capacity building and educating. So we've been providing references or links to websites, photographs of other relevant case images, and even in some cases, even go as far as providing some treatment recommendations if applicable. In the cases where a definitive diagnosis hasn't been possible, the factors precluding a definitive diagnosis have included lack of sufficient clinical history, which is something that we encounter as well, right, in our setting. Obviously, absence of confirmatory immunohistochemistry is an issue, and in some cases, technical issues, such as air drying artifact or tangential sectioning, poor image quality, in some cases, inappropriate field selection. But I would argue that actually, the last couple of points in terms of the quality and even the immunostaining to some extent, all of these can actually be overcome by capacity building. So even building capacity for basic ancillary diagnostic testing. So I think it does go to show that if properly used, this technology is actually quite powerful. So since 2012, we've really expanded the activity to other areas of the world, not just Africa, so Iraq, Botswana, and South Africa. And interestingly, and I think this kind of reflects the scalability and replicability of the model, all of these additional interactions have really stemmed from a pathologist who's come to MGH as part of an observership or rotation. Actually, the Iraqi pathologist, very interesting, he presented a poster at the 2008 USCAP meeting, or maybe it was 2009 USCAP meeting that was in Boston. Not the last one in Boston, but the one before that in Boston. And I just started chatting with him, and then we established this contact. He came to MGH and spent 3 months with us doing HemePath sign-out as part of, that was sponsored in part by the American Society of Hematology Visitor Training Program. And since then, we've just had an ongoing relationship on email and sharing cases with each other. So, I think it goes to show that you can offer a lot when somebody leaves. It's not just, okay, well, you're going to go back to your lab and, it's going to be tough, but you'll manage. I think that there's a lot that we as pathologists can offer. So teleconsultation, so, you know, I think the other thing I think that's been interesting is people tell me in other labs, like, oh yeah, I mean, I do that, somebody will send me a case by email and I'll give them an opinion. But I think one thing that's been really critical is we've tried to keep track of the cases. So we've tried to log for all of them how many images are posted and what specialty they end up in and what our turnaround time is, because I think that's also an important aspect of really showing the applicability of this type of model. And so it's actually been very interesting and allowed us to do to ask and answer some interesting questions. So this is a graph showing the teleconsultations by subspecialty. And so probably like the fact that I'm a hematopathologist, obviously, so probably part of the fact that we get a lot of hempath is maybe an aspect of that. But you know, the most popular subspecialty areas in which cases are posted, so heme, derm, soft tissue, and cytopathology, these all typically, at least here, would require fellowship or subspecialized training beyond residency. So I think that's an important feature. And interestingly, skin biopsies comprise about a quarter of the teleconsultations, but only from the, if we actually polled the hospitals that are posting these cases, only about 5 to 15% of histology cases originating from the hospitals. So this kind of led us to ask a few questions. So why so many skin biopsies? This is a little bit tongue-in-cheek for me personally, because when I started my fellowship, my hempath fellowship with Dr. Harris at Mass General, derm path is not really my forte, and I was disappointed to discover that she gets a lot of skin biopsies for cutaneous lymphoma or mimics, and I kind of said to her, maybe unthinkingly in the first weeks of my fellowship, I didn't know you got so many skin biopsies, I'm not sure I would have signed up for this, having known. But so this is a little bit tongue-in-cheek and a reminder to me to really acknowledge the dermatopathologists in our department for really helping me with these, because this is not really my area. But we did ask ourselves this question because it seemed a little striking to us why there were so many skin biopsies. So obviously, as I alluded to, there are no fellowship training programs in DermPath, which is obviously a very popular fellowship experience here. There's also no board-certified dermatopathologists kind of as a result of that. The other thing that's sort of interesting is because there is a high prevalence of HIV in some of these countries, one hypothesis, we don't really have a lot of proof for this, but one hypothesis, because we would see that a lot of cases would be posted as you know, it was biopsied for a question of Kaposi sarcoma. So I think that a lot of lesions in HIV positive patients end up maybe having, because they have sort of a high pretest probability of being Kaposi's, end up getting biopsied, whereas they might just be ignored in someone without that history. And interestingly, I think that one thing that is arguable is that skin biopsies are really in some ways an ideal specimen type for still image-based telepathology because they can be obtained relatively easily. It's not something that requires a surgical procedure and general anesthesia. And they're typically also small in size, and that really minimizes some of the limitations of sampling bias and field selection. And so this case, I think, actually kind of illustrates all of those points. This was one of the cases that was posted on the platform. A 39-year-old HIV-positive man with lower extremity lesions, including both these irregular hyperpigmented patches and plaques, as well as these solitary umbilical papules, so kind of two different types of morphology. And so this was biopsied, and the biopsy, as one might have expected from the appearance of this lesion, showed molluscum bodies within the epidermis, but there was also an underlying dermal proliferation of spindled cells, as you can see here, with kind of slit-like vascular spaces and even focally some red cell extravasation. And so an HHV8 stain was performed and was positive in this area, confirming a diagnosis of both molluscum contagiosum and Kaposi sarcoma in the same skin biopsy, so both an inflammatory and neoplastic lesion, both of which have a higher prevalence in this patient population. So this kind of led us to undertake a focused review of 29 cases that were submitted over the course of 3 years, the first 3 years of the program. So even at that time, you can see a smaller number of cases, but still comprised about a quarter of the consultations. And a lot of this work was done by one of the DermPath fellows at the time, now a practicing dermatopathologist in Chicago, Devin Gimbel. So the glass slides, we actually decided to perform a concordance study, which is sometimes done to show the validity of a telepathology platform. So glass slides were available for review in about 3/4 of these cases, and so that allowed us to measure the diagnostic concordance between the static image and glass slide-based diagnosis. Importantly, this review was conducted by the same dermatopathologist who reviewed the prior static image based diagnoses, but it was done several months after they had reviewed these static images, so there was a sufficient washout period so that they wouldn't have a visual memory, hopefully, for these cases. And again, this is illustrating sort of a case that was posted, so you have the history. As you can see, a number of clinical images were posted in this case of a bullous lesion, and then the microscopic images, and you could expand these to see, expand on the thumbnails to look at the images, and then a diagnosis would be posted, and then we would get the slides of this case at a later point. So, so interestingly, just to kind of look at some of the statistics from this, these DermPath cases originated from all 4 hospitals that were using the system at the time, but more than 80% were from locations with solo pathologists, so staffed by 1 pathologist. And about 28% of cases included clinical photographs in addition to H&E images. And the static images were diagnostic in about 3/4 of the cases, higher degree of diagnostic certainty in cases with clinical images. This might be expected, a very important correlation for dermatopathology. And as you can see, these span both inflammatory as well as neoplastic lesions. That one case I illustrated was the combined inflammatory neoplastic case. And also several unusual entities. And I think that this turned out to be educational from both sides, both the trainees here who were involved in this and the pathologists here who were involved in the study, as well as the pathologists in East Africa who were involved in the study, learned a lot of new entities. In terms of the diagnostic concordance between static and glass slide diagnosis, it was quite high, 95%. There was actually one case that was discordant. It was a case of toxic epidermal necrolysis. So the static telepathology images were essentially non-diagnostic, and it turned out that on glass slide review, there was a separate smaller fragment of tissue, and this on high power magnification turned out to really be the diagnostic field. And so this is really an example of the pitfalls of this technology, right, where you don't have the whole slide in front of you to examine. You're relying on someone else to take photographs, someone who's hopefully knowledgeable about pathology, but it can still show how critical or how biased you can be if you don't have the whole slide to look at. But in general, it was, I think, a very positive study. The participant feedback was that the technology was relatively easy to use with rapid access to second opinion consultation and an increased sense of security on difficult cases, which was really some of the things that we were trying to achieve for this group of pathologists practicing in East Africa, as well as an increased awareness of rare or unusual diagnoses. But I think that, again, this was something that went both ways. And they did appreciate the educational aspects of the responses, as well as a patient-centered focus with discussion of clinical presentation, as well as management in some cases where the dermatopathologists felt like they could even make some management recommendations. In contrast, it was interesting that cytology cases appeared to be underrepresented relative to the volume seen. There's actually quite high volume of FNAs performed, and so this seemed to be surprisingly low, less than 10% of cases. And so we also did a separate sort of telecytology study, and this was really driven by the pathologists based in Nairobi and Kisumu. They really sort of drove this project. They posted still images of 40 consecutive cytology cases that were considered challenging. These included both cervical smears, and I should just note these were conventional smears, not liquid-based preparations. Again, the technology is not as readily available for the liquid-based preparations, as well as FNAs and fluids. And pathologists in the Aga Khan health system based in Tanzania and Kenya with varying levels of experience independently evaluated these static images. And again, we conducted a concordance study with glass slides. And this is again showing one of these FNA cases of an ovarian mass, which had features that were felt to be consistent. I'm not a cytopathologist, but felt to be consistent actually with, I think, with these squamous cells with the mature cystic teratoma. So the diagnostic concordance here actually ranged quite a bit, and it ranged from 70 to 90%, really much higher for the more experienced pathologists in the group, as might be expected. They also demonstrated greater comfort with the technology and higher levels of confidence in their diagnoses. So there was some discordance between the last slide and telepathology diagnosis in about 32% of cervical smears, and you can see in terms of the causes of the discordance, sampling bias and image quality turned out to be a major issue. For fluids, that did turn out to be an issue, but I think some of them were just difficult cases, just very challenging cases, known sort of misinterpretation of a known diagnostic pitfall. So I think that this certainly points to some challenges with this technology, perhaps more so for some specialties like cytopathology versus, say, dermatopathology. Perhaps there's greater susceptibility for technical factors and sampling bias, since you have really a whole slide of individual cells smeared out that need to really be reviewed, and pointing to the need for additional training with this technology for referring and consulting pathologists, and really kind of highlighting the fact that in this type of teleconsultation, knowing the diagnostic questions of importance ahead of time can actually be very helpful to sort of zeroing in on what's needed for a particular consultation. So just to conclude about the static digital telepathology system, I propose that this is really a simple, cost-effective, reliable, and replicable, as well as sustainable model. I mean, we're still doing it 8 years later for diagnostic support to pathologists in resource-challenged settings. There's a limitation of sampling bias, but this seems to vary across specialties, and I think just awareness of this, as well as additional training, can help to overcome some of the factors, if not all. I think the one thing that for me is very important, and a lot of people have asked me this over the years, is, well, there are whole slide imaging-based systems that are now, of more reasonable cost, and why don't you just put one there? And, we could. That's certainly something I've grappled with, and why not just kind of make it easier for everyone to put them there? But for me, personally, I really feel like we really actually want to leave the diagnosis in the hands of the pathologists in East Africa, because the whole point of this isn't to take over the lab and start to be their pathology department, it's to provide support. And if you take away from them just the aspect of looking at a slide and studying a slide and learning from your mistakes, I actually feel like that might actually be a detriment in the long run, and I know that not everyone agrees with me on this, so it's certainly something that I think is open for discussion, or how to use whole slide imaging in an effective way that doesn't kind of overtake the responsibility of making a diagnosis. And one model that's been proposed, which I think would actually be very feasible, is sort of a hub and wheel, a sort of spoke and wheel approach, in that a tertiary-based lab in East Africa could be the referral center and have whole slide imaging scanners at smaller hospitals with solo pathologists, but still have all of the diagnostic work done in the region to build regional networks and regional support. And that's something that I think would be very sustainable, and something that I would be very much in favor of. But somehow the thought of just doing the whole slide imaging and making the diagnosis for them never really appeals to me. But I may be wrong, and I think a time will tell which kind of model sort of wins out. But I think here, at least, the critical role for the referring pathologist is maintained, and that's been very important, I think, in terms of educating and building capacity. And we've noticed that really hallmarks of successful teleconsultations is really about clear communication of diagnostic questions and consultations that I think, again, aim to educate rather than to just diagnose, so that we empower pathologists to be able to grapple with the challenges when they encounter a similar case. This has also really actually been a rich source of ideas for collaborative research endeavors, and to help answer questions of importance to both their practice and our practice here. And so I just want to spend the last 15 minutes or so going through just describing some preliminary data from some ongoing collaborations that we have with some pathologists overseas, mostly based in East Africa. So I'm going to talk about two lymphoma studies that have collaborators, again, in Nairobi, at MGH and Vanderbilt and here. And we actually presented preliminary data on this at the IAP. So this was the IAP in, I think it was the IAP in Thailand. So it was the first IAP that was held in Asia, I believe, in Bangkok in 2014. And I just want to I also just wanted to mention that in each of these cases, the presentation and the initial authorship for those presenting posters was by the pathologists in East Africa. And I think that's also very, very important, because another issue that has evolved over the last several years is that developing countries turn out to be very rich sources for research specimens. But again, just not involving, I think, the pathologists in that research it doesn't really help in the long run, because they are the ones who are going to be diagnosing 3/4 of the cancers in the world. So they really need to know how to approach these questions, right? And then a study of Kaposi sarcoma, really driven by the pathologists at the Aga Khan Hospital in Kisumu, with collaborators here at MGH and in Miami. And this was actually also presented not only at the IAP, but at last year's USCAP meeting in Boston. So the first project is Characteristics and Classification of High-Grade B-cell lymphomas in resource-limited settings. So just a bit of background. High-grade B-cell lymphomas include DLBCL, diffuse large B-cell lymphoma, Burkitt lymphoma, and B-cell lymphoma with features intermediate between the two. And their accurate classification really relies on typically a panel of immunohistochemical stains, and in many instances FISH, which is difficult in resource-limited settings. And so we sought to define a practical approach to diagnosing and classifying high-grade B-cell neoplasms in such settings. So what we actually did was we had consecutive cases of cases previously diagnosed as diffuse large B-cell lymphoma from 3 Kenyan hospitals, and they were reclassified using both morphology and a panel of ancillary studies. This evaluation was performed independently by 4 pathologists, 2 based in Kenya and 2 based in Boston. Most cases had relatively limited clinical data, including HIV status. And the studies that we focused on in terms of immunohistochemistry included CD20, CD10, BCL6, BCL2, MUM1, so essentially B-cell markers and markers of germinal center and post-germinal center differentiation, as well as Ki67 for proliferation and MYC, so this common clone that's been available in the US for the last few years in terms of sort of predicting for an underlying MYC rearrangement. Selected cases were stained for some additional plasma cell markers. EBER was done in all cases, EBV in situ hybridization, and in selected cases we did do FISH for MYC and BCL2. And interestingly, the results of reclassification were quite striking. So on reclassification, only about 2/3 of cases were felt to actually be diffuse large B-cell lymphoma. A significant proportion were consistent with Burkitt. So it actually seemed like these were sort of, in fact, being underdiagnosed in a malaria endemic and a high HIV area, which was interesting, not expected. And plasmablastic lymphoma comprised a few cases as well. So the large cell lymphoma cases, there was a median age of about 51 years. And although this wasn't sought to sort of be a proper epidemiological study, this I think is a little lower than the median age of DLBCL patients here. Interesting, there was a slight female predominance, and about half the cases were extranodal. All were CD20 positive, and about half were a germinal center phenotype, and 16% were double expressing, so high levels of BCL2 and MYC co-expression, which is, again, in the last couple of years has been recently defined as a poor prognostic subgroup of diffuse large B-cell lymphoma. So the proportion of germinal center and double expressing are about similar, I would say, to what we see here. Interestingly, perhaps, again, assuming that it was because of the prevalence of HIV, even though we didn't have the history in all the cases, there was actually a relatively low EBV association, 3 out of 43 cases. One of them was in an elderly patient. Interestingly, the median Ki67 proliferation index was relatively low. So in many of these cases, we were really making the diagnosis based on morphology. The Burkitt patients had a lower median age as expected, and several extranodal cases. And all of them had like the classic immunophenotype for Burkitt, so CD20 and CD10 positive, BCL6 positive for the most part. There was one BCL2 positive case. The rest were BCL2 negative. So the BCL2 positive case did have Burkitt morphology and high levels of MYC staining, and we did perform FISH on this case to show that MYC was rearranged with an intact BCL2, and I believe the patient was a relatively young age, and it was also an abdominal ileal-based tumor, so sort of a classic kind of presentation for Burkitt's. Again, interestingly, the MYC expression was high, as might be expected, but the antibody worked quite well on this tissue. And the Ki-67, again, was high, but actually relatively low compared to what we see in our setting, which is a little bit interesting. And then the plasmablastic lymphoma patients, as I mentioned, there were only 3, but they all had plasmacytic or plasmablastic morphology with a plasma cell immunophenotype. Importantly, they were negative for HHV8, so we confirmed that in all of them. So this wasn't sort of a primary effusion lymphoma with an unusual presentation. And they did seem to have MYC and EBV relation, although it's very hard to draw conclusions based on these small numbers. So it's interesting that a substantial fraction of these cases were originally diagnosed as DLBCL were reclassified as another subtype of high-grade B-cell lymphoma, and particularly Burkitt's and plasmablastic lymphoma are treated more aggressively in our setting, so this does have clinical consequences. But I think one thing that really arose from this is that really morphology with 4 immunohistochemical stains, CD20, CD10, BCL2, and MYC, can really be helpful in distinguishing Burkitt from DLBCL. So we sort of came up with this diagnostic algorithm where if you have CD20 positivity, you can essentially do these 3 other stains without really resorting to FISH and be fairly certain about a diagnosis of Burkitt lymphoma with these 3 stains. And it really points to, I think, the utility of the MYC antibody. We kind of think of it as more of a screening tool, maybe a prognostic tool, but I think in a setting where FISH is not readily available, it really becomes a diagnostic tool, and optimizing it for its appropriate use in that setting really highlights that role. And so that's kind of a future direction that arose from this study is the other 3 antibodies are actually validated in the immunohistochemistry lab at AKUH Nairobi, but they don't have MYC validated as right now, so they are actually working on it because they really now see the utility of this antibody. So we hope to prospectively validate this algorithm and have the stains now done there, as opposed to these were done at MGH. And it also points to the high variability of MYC and Ki-67 staining was, again, something that was not expected. This may be related to technical differences in tissue fixation and processing, or just there's often more delay from the time of biopsy to processing, and it may suggest the need for lower diagnostic and prognostic cutoffs in these settings. So the second lymphoma study I wanted to touch on is about nodular lymphocyte predominant Hodgkin lymphoma in Kenya, and its features in comparison to Western cases. So this is a distinct subtype of Hodgkin lymphoma that comprises about 5% of cases, and it differs from the classical variant of Hodgkin lymphoma in terms of morphology, immunophenotype, and rate of EBV association. But similarly, it's composed of few neoplastic cells and a background of reactive small B and T cells. And as classical Hodgkin lymphoma shows some geographic variation with higher rates of certain subtypes and EBV in developing countries, the same is not certain. It's not certain whether the same is true for nodular lymphocyte predominant Hodgkin lymphoma. And there's in fact some older studies suggesting that nodular lymphocyte predominant Hodgkin's, which is usually thought to be EBV negative, may actually have a higher prevalence of EBV association in developing countries, but this is unclear since this is based on older studies. And so we undertook a detailed sort of retrospective morphological and immunohistochemical analysis of 10 cases of nodular LP Hodgkin's, and these were actually cases where the glass slides were sort of sent to me in consultation. I've been doing pro bono consults on for glass slides as well for the lab in Nairobi on cases where they just have a lot of difficulty, and they just sort of feel like the telepathology isn't going to be sufficient to be able to provide a diagnosis. And so we did an extensive IHC workup. So some of these stains were done there, some were done here in our lab. And again, clinical data was limited in most cases. So the results, actually, clinical and pathological features very similar to Western cases. So again, it's a limited study, but this is a rare subtype. So 10 cases is actually a fair number. The median age is at 35 and high male to female ratio, so similar to US-based cases, and mostly peripheral nodal disease, which is what we see here. And the morphology was sort of the typical B-cell rich nodular areas that we see here. There were some variant patterns seen as well, similar to the variation that one can see in nodular LP here. There were some unusual features, so most of the features have these classical nodular areas. There was some focal fibrosis and even occasional eosinophils seen in some cases, but for the most part, no cases really had features of classical Hodgkin's or some other subtype of non-Hodgkin's lymphoma. And in terms of immunohistochemistry as well, very similar features to Western cases. And the thing that, of course, we were interested in was the EBV. So LP cells were EBV negative in all 8 cases that could be tested that had intact RNA. And it was interesting that 2 cases did actually contain rare EBV positive small lymphocytes, indicative of prior infection rather than infection of LP cells. So these are just some more images highlighting the similarities in terms of immunohistochemistry. So we concluded that Kenyan nodular LP shares clinical, morphologic, and immunophenotypic features with Western cases, as well as a lack of EBV association, and hypothesized that perhaps some of these earlier studies pointing to higher rates of EBV positivity in developing countries may have included cases of EBV positive lymphocyte-rich classical Hodgkin's lymphoma that may not have been sufficiently immunophenotyped. And of course, one thing that we noticed is it does seem like there's a lot of nodular LP, even relative to the Hodgkin's in this patient population. That's unexpected, but that really requires a little bit more study to say that for sure. And then finally, just to touch very quickly on the Cathasies study, this is looking at signaling pathway activation by immunohistochemistry. As we know, this is a vascular tumor associated with HHV8 with a high prevalence in equatorial Africa with both HIV-associated and endemic types. And it typically goes through a progression of patch plaque to tumor nodular phases, and there's a high recurrence rate after surgical excision, as well as a potential for widespread dissemination and visceral involvement in HIV-positive patients. And the current therapeutic options beyond surgery are limited to radiation, chemotherapy, and interferon alpha. They have some limitations both because of low efficacy and high toxicity. And there is some evidence in prior studies of activation of mTOR, PDGFR, and c-KIT signaling pathway molecules in the pathogenesis of Kaposi sarcoma. And all of these have targetable players in their pathways, suggesting perhaps a therapeutic role for targeted inhibitors such as rapamycin, an mTOR inhibitor, and Gleevec. So our goal was to study a large number of human tumor samples for overexpression of these pathway proteins and perhaps to then lend additional support to the potential role for targeted therapy. So we actually took a large number of cases, again identified biopathologists and very painstakingly cataloged biopathologists based in Kisumu, which again is right along the equator, so very high prevalence of HIV and high prevalence of Kaposi's, and stained for various pathways of activation of these molecules in these pathways. And so we actually did this through tissue microarray cores, and the pathologists from Kenya spent some time at MGH doing an observership in both HemePath and DermPath, and during that time actually was involved in choosing areas for tissue microarray construction. So really got some exposure, I think, to how this process really works. And we stained the histologic sections of the master blocks for these various markers. And using a scoring method that combined both intensity and extent of staining, and thereby yielding a factor of the two and a modified H-score method. And this is just showing here at the bottom some of the staining results in an example of a case that was positive for most of these. And so this actually showed that at least as far as sort of the targetable proteins, so c-KIT, PS6, which is downstream in the mTOR pathway, the AKT pathway, and PDGFR, there was actually a fairly high rate of positivity with a high prevalence of strong staining for the molecule downstream of AKT. And there was no significant difference in staining for these in patients with lower preserved CD4 T cell counts, so we actually had access to that data. And interestingly, there was a large proportion of HHV8 negative cases, which appears to be really attributable to intratumoral heterogeneity based on staining of whole tissue sections. And this is just a graphical representation, again, showing staining of all of these with particularly strong staining seen for PS6. So it seems like upregulations of components of these pathways can be confirmed by immunohistochemistry in a large cohort of Kaposi sarcoma tissue samples, and PS6 in particular demonstrates a high proportion of positivity, with most tumors showing strong positive staining. And that the other thing that I think arose out of this is that the overexpression appears to be independent of CD4 T cell count, meaning that even patients with a low CD4 T cell count could potentially respond to targeted agents. So just to conclude, so there are certainly very large number of challenges of pathology practice in low-income countries, but I think these challenges do provide a number of opportunities, some of which I've just touched on. Educational and diagnostic support to build skills of local faculty, really highlight the role and importance of pathology to the broader medical community in those regions, as well as involve pathologists in resource challenge settings and collaborative research endeavors to answer questions of importance across practice settings. So obviously something like the Kaposi study has applications both here in the developed world as well as in the developing world. So these aren't questions that are just restricted to one region of the world. And I think that one thing I really learned from all of this is to really focus on relevant and sustainable models that are both patient-centered and pathologist-focused, and I think that really does help to drive success and define what works and what doesn't work. So with that, I just want to acknowledge a large number of people at MGH and in East Africa for their support, and I'm happy to take any questions. Thank you so much. Yes, hi.
Well, I'll start off. I want to congratulate you for what you're doing. I think it is tremendous. But as you indicated on your summary slide, you really are just right at the tip of the iceberg.
Yeah.
As you know, the Aga Khan is the MGH of the developing world. And there are huge areas in the developing world that really are completely inadequately served. For example, I had an opportunity to consult in Namibia a few years ago, and there basically are no Namibians trained in pathology in Namibia. They basically have one pathologist in the whole country, and that pathologist was trained in South Africa. Most of the other pathologists there were trained from around the world, including as far away as Russia. We have a huge responsibility, I think, to help the developing world bring up the quality of medicine and pathology around the world. And I would like you to comment on how you think we can do that.
Yeah, I mean, I think, and you're right, and that's something I sort of wanted to preface at the beginning, because we partnered with an NGO with a lot of established connections and a hospital system, and it is a private system. I think that also made the track somewhat easier for us, and I think it's sort of a question of whether to go after some low-hanging fruit or not, and certainly there are areas where the challenges are even greater than this. So here I'm talking about a place that actually has basic immunohistochemistry, has actually reasonable histology, and has a training program.
Right.
So yeah, there's definitely differences. So one thing that I would say is, I think by establishing connections with established programs like this, it does allow you to open doors to support other programs as you have done. So just one example that I can think of is MGH also has a collaboration with a much sort of more, I guess for lack of a better word, primitive pathology lab. They're actually trying to build a cancer center in a rural part of Uganda, in an area called Mabarara. And so I actually haven't had the opportunity to go, but several pathologists in my group, one in particular, has gone there several times. And it's very, very difficult. So they're just now starting to get a pathology program in place, and they have a couple of trainees that they're hiring, and they've basically been staffed by a pathologist who's actually a volunteer, well, not really a volunteer, I mean, she is getting paid, but she's from Cuba. She's been there for several years, so she's sort of doing it as part of a Cuban medical mission effort. I think that country actually has a very strong healthcare system and does have outreach worldwide. So one thing, for example, is just getting their histology lab up to speed. And so we've been working in terms of getting them equipment, getting them processors that have been used, sourcing them from places in Europe. And just recently I heard that one of the immunohistochemistry techs from the Aga Khan University Hospital in Nairobi is going to go there. And we're actually going to pay her salary to go there and spend 2 months teaching them some basic histology and immunohistochemistry and teaching their techs. And I think that, one thing we also discussed is whether to send one of our own techs there at actually a greater cost. I think things like that, those regional types of collaborations are so great because now they're going to have this connection with Nairobi, a neighboring country, and with Kenya, in a neighboring country, and they'll always have that establishment. They'll be in the same time zone. All of those things actually make a huge difference. It will be much easier to maintain that contact. So I think things like that, even if you are starting with, for example, there are trainees coming from programs in South Africa, Nairobi, who need to do a practicum. The way I think their system works is they need to do a practicum for 1 or 2 years before they can really be considered, practicing pathologists. So giving them the opportunity to train in a solo environment, for example, like Namibia, is one thing that I could think of. So I think, I think one thing that has been frustrating that I've seen is that the approach does seem very fragmented. But I think that's why, having the opportunity to even come and talk to you and just having the communication here, if we can even unite on some level in some of our efforts, I think that can go a long way to building. And I think what we should try to do is really foster regional initiatives rather than having a kind of a top-down approach.
I'll ask you a question.
Yes.
So one question is actually about malpractice insurance.
Yeah.
So how does that work in terms of these cases that you're providing a professional opinion on?
So as far as the telepathology, what we've done is we did go to general counsel at MGH. It was sort of something that the department chair said, we should just kind of get this clarified. And we've really sort of promoted it as an educational endeavor, that what we're trying to do is use these cases as a platform for education. There is a disclaimer with each case in that we're not providing, a true diagnosis in the sense that we don't have the opportunity to review the full slide, and that, we have language that essentially has been sort of approved by that. I will say because I've done some cases pro bono, so those ones I actually get the glass slides of, so I have those logged in as consults, and then I just issue a path report, so then I think the same thing then applies. Obviously, you're hopefully covered, for your malpractice by our insurance. But as far as the telepathology cases, we sort of just build it as an educational endeavor, and we have a disclaimer. Truthfully, I think that the environment is much less litigious there than it is here, so I'm not that concerned that something would ever untoward come out of it, and I think they're just so appreciative to have any input. But there have been some instances where I've shared the case with someone and they just prefer that their name not be used, and of course it's very easy to just say I showed it to, a colleague in breast pathology. You don't really have to say it was Dr. So-and-so, and that doesn't seem to bother them.
Right.
So, Yes?
My experience with trying to do telepathology with developing countries is that one university hospital in particular had gotten a slide scanner and tried to send the mount or post the digital files for folks here in the US to review, and there was a huge issue with transferring the files, the software to look at the files, and we tried to partner with ASCP.
Yes, they have something, a cloud-based.
Right.
Yeah.
And ASCP said, only if you pay us.
Really?
Because they said, yes, they said the cloud space is expensive and the software is expensive. And ASCP doesn't own the cloud space, they rent it, and they don't own the software, they license it.
Okay.
So they said we would partner with you because they're already doing the Africa initiative.
Right, right.
So have you had any experience with that?
So, because we've used a still image-based system, and I mean, I have to say sometimes the system hasn't, like the actual platform, the screenshots I showed you, there have been intermittent times where the server in Karachi's gone down and then they just email the images as an attachment. So I think that's in some ways kind of a nice aspect of the still image based system. The image file sizes are small, images are small. You can attach them to an email at a very basic level. If you want to have a little web-based platform like this, you could have design one with probably somebody who has some web writing experience could probably design one with little difficulty. So I haven't had much experience with the whole slide imaging-based systems, but I think that those are challenges inherent to it. And again, going back to my earlier point, I really kind of feel like it takes away the diagnostic aspect. I mean, the sort of the basic thing that we do as pathologists, we sit and we look at slides under our microscope, right? Like that's something we as surgical pathologists do. And I think like somehow the thought of like feeding it into a scanner and just having someone else do it for you just kind of takes away from it. So I'm actually not a big proponent of those systems. And I would say that maybe trying something on a more simpler level. The one thing that we have had issues with is it takes time to photograph a case. I mean, you and I, all of you, have photographed cases for talks and such, and it does take a lot of time. But maybe one thing is if they have the scanner, could they, like if you have the whole slide scanned locally, could they take screenshots of various areas and send those?
Oh, no, and that
that might be easier.
No, I've even brought a microscope somewhere with a laptop and one of those
the USB camera type things.
Yes, it's right in the
you can have those now. Yeah, when we did this, we didn't even those wouldn't exist. Yeah, the oculars. Yeah,
and several people in this room contributed bits and pieces that all got packed in a roller bag and set up, and I get the still photographs as email attachments, as Gmail attachments, and just look at them on my phone.
Yeah, I actually think simple is the way to go with this. I mean, I actually think that's a more sustainable model because in a way, what if the power runs out or, the internet goes down? So I think that going for along models like that is actually a better way, and it has greater sustainability, personally. So, yes?
So for these telepathology cases, is there a direct kind of face-to-face interaction with the pathologist? And,
we haven't done that. We haven't done real time, partly because of the time zone difference. But one thing I have done is sometimes given them lectures, like on Skype or a webinar-based lecture to their residents. So they identify a topic area, but we haven't been doing real time. It's all been asynchronous still image as far as the telepathology is concerned.
All right, thank you very much.